So just a disclosure, some of what I'm talking about is in my books. So Rosalind Carter says that there's only 4 kinds of people in the world, right? I love this quote. People who have been caregivers, who are currently caregivers, who will be caregivers, or those of us who will need caregivers. That covers just about everybody. And we all know these basic facts, that dementia is a chronic illness that's affecting an increasing number of people in our population. 1 in 8 older Americans has Alzheimer's disease currently. Nearly half of persons over age 85 and older have AD, and I work on an epidemiological study in Seattle, and we see people in their 90s and 100s that are developing Alzheimer's. We used to think that if you got old enough you wouldn't get it, and that's just not true. And individuals are now being diagnosed earlier and earlier, and so they're going to be living for longer and longer periods of time with the disease. And the toll that this is taking on families is enormous, right? I mean, families are providing the bulk of the care for folks with dementia. 2012, 15.4 million family and friends provided 17 billion hours of unpaid care. Many of these caregivers are caregiving from a distance, taking care of parents who live far away. The stress levels are very high for folks with dementia, and the costs, financial costs for individuals and for our society are staggering. So, embedded in this growing problem of increasing numbers of people with dementia is the fact that behavior and mood challenges are practically universal in persons with dementia. They tend to increase as the disease progresses. They're the primary source of stress and burden for caregivers, right? I mean, if my mother doesn't remember what she had for breakfast, that's not going to bother me. What's going to bother me is if she's sitting and she's crying and says her life isn't worth living. It's these mood and behavioral problems that really tug at our hearts. They're a common cause of institutionalization, why people can't remain at home, and they can be difficult to treat. They often require more than one kind of intervention. They're a moving target. You figure out how to solve one problem, and then there's going to be a new problem pop up, kind of like, you know, pounding those moles when you're the kid. You know, one thing pops down and it goes back up. So what can we do to help? And what I'm going to be talking to you today about is just some very practical strategies to approach behaviorally, non-pharmacologically, these mood and behavior challenges in persons with dementia. And my goal would be that all of you, when you walk out of here, will have some tools in your kit that you can begin using immediately for working with these kind of challenging problems. Why do we want to focus on behavioral treatments? Well, you want to focus on behavior because we can't stop the progression of the brain diseases yet. We don't have the tools to do that. But we can change behavior, and if we can change behavior, we can improve functional status, and we can increase quality of life for the persons with dementia and for the caregivers. There are many, many studies that are out there now that demonstrate non-pharmacological interventions for mood and behavior challenges in Alzheimer's disease are efficacious. Many. I'm going to be talking to you mostly about the research that we've done up at University of Washington, but all of these non-pharmacological interventions have things in common. They all look at mood and behavior changes as not being problems to be solved. They are attempts by the person who has the disease to communicate with us, to get their needs met in some way. And understanding these behaviors requires us thinking about kind of where the person has been, who they were before they developed the dementing illness, but also what's going on in the current circumstances that might be contributing to these problems developing right now. They focus on the dyadic interaction. We're not trying to fix the person with dementia. We're looking at the relationship between the person with dementia and the person who's caring for them and trying to focus on how that dyadic interaction can be changed. We see problems with verbal communication as being a major source of these mood and behavior changes. That effective treatment requires responding to what is the underlying need, or what is it that the person is trying to communicate. That's what we want to understand and when we come up with our interventions. And we emphasize keeping records, logging, keeping track, observing. So I'm going to try to teach you to be good observers today. And we really focus on the importance of quality of life. Dementia is a chronic illness. People live with it for many, many years. And we want to increase the well-being, the sense of self-esteem, the feeling of accomplishment that people with dementia have at all stages of the disease, to the extent that they're able to experience these things in their own ways. So the work I'm going to be talking about today comes, as I said, from research that we've done at University of Washington, which we have come to call the Seattle Protocols. These are just some of the areas that we've targeted over the years: depression, agitation, sleep, physical inactivity. We've worked in adult family homes, we've worked in family caregivers, we've worked in assisted living settings, we've worked in nursing homes. All of these protocols, again, focus on partnership between us and the caregiver. They are standardized. We have a standardized approach that we're following to solve problems, but we're individualizing it to the unique situations and the situation of the person that we're dealing with. They have core components: realistic expectations, understanding dementia education, good communication, something we call the ABCs of problem solving, and increasing pleasant events. And we've had tremendous success with these outcomes, with these studies. We've reduced both care receiver and caregiver depression. We've improved physical function, reduced institutionalization due to behavior problems. We've improved sleep in both caregivers and the care receivers in all of these various settings, improved quality of life in early stage folks. So we've been very successful. And what I'm going to try to teach you is how to do what we've learned how to do. And in my own clinical work, I've taken what we do up at Seattle and I've turned it into an acronym called DANCE. So I'm revolving this talk around my acronym because I think it makes it easy to remember these pieces. Anyway, it makes it easy for me. So D in the DANCE stands for don't argue. I'm going to talk about the communication, verbal and A stands for acceptance, for having realistic expectations of what as a caregiver and what the person you're caring for is capable of, given their stage of disease. N stands for nurturing yourself. The caregiver has to take care of him or herself or they won't be able to provide the quality of care that they want to provide. Creative problem solving, that's where the ABCs come in, and then enjoy the moment, talking about pleasant events. So, if we start with communication, I used to tell people, you know, if you don't remember the acronym, if you just remember this D, don't argue, you'll have 90% of the work done. You know, it's the one thing, any relationship, whether it's someone working with someone who has dementia or me talking to my spouse, you know, any relationship's quality is affected by the quality of our communication. And as cognitive decline progresses, people become more and more sensitive and attuned to nonverbal cues because they're having increasing difficulty with verbal communication, both communicating what they want to express and understanding and taking in what's being communicated verbally to them. So they become very sensitive to nonverbal cues. I remember a caregiver telling me once about that night before I saw her, she had minestrone soup for dinner. She had a nice white linoleum floor that she just mopped that afternoon. And her husband knocked the bowl of minestrone soup on the floor. You know, burnt himself, made a huge mess. And she said, I told him, that's okay, honey, don't worry about it. And he got very upset. And in reflecting on it later, she realized her words were, that's okay, honey, don't worry about it. But her manner was, she was whipping to get the cloth and she's wiping it up and her face is all scowly and her tone of voice is really irritated. So what was the message he got? Was the message, that's okay, honey, don't worry about it? No, the message he got was she was really upset and he didn't understand why she was so upset, but it started him going too. And then they were going down that path. So nonverbal cues become very important. Rapport building trumps information or gathering accuracy of facts. Had a caregiver tell me once he was so embarrassed because when I've been interviewing his wife, she was talking about this great trip she had recently going to Hawaii with Hillary Clinton sitting in the seat next to her. They had this wonderful conversation and Hillary was so nice and the caregiver was appalled because of course They had not taken a recent trip to Hawaii at all, let alone sat next to Hillary during that trip. And he thought his wife was lying. And he didn't want me to think badly of her. And so a lot of the work I had to do with him was to understand this was a wonderful memory for her. The truthfulness of the memory was irrelevant. What mattered was she felt valued and had a purpose and meaning, and it was engaging for us to have this conversation. And so it was a good thing, not a lie that needed to be, you know, taken away from her. So whenever there's a problem, check to see if there's communication breakdown. I like acronyms, and so, you know, I've also turned polite into an acronym that's a communication acronym. But you don't have to think about that acronym. You can sort of think about, isn't it true that a lot of our problems communication-wise with people with dementia would be reduced if we were just more polite? If we weren't talking about them like they weren't there, or if we weren't using a tone of voice that is patronizing, or like you're speaking to a child, or if you're not in a complete hurry or rushing about, or, you know, if you were kind of being more patient and listening and taking your time as opposed to rushing around. A lot of it really does kind of come down to politeness. My colleague Linda Terry, she has a little jingle, listen with respect, comfort, redirect, that sort of takes all of these good communication skills and boils them down. So you think about it, listen with respect. When a person says to me, I hate you, does that mean he really hates me? Or does that mean he's really mad because I won't give him the car keys? Or, you know, does that mean I'm really scared because I don't have a clue who you are and you just showed up at the front door to talk to my wife? You know, what is listening with the heart? And all of you who are in this room and work with dementia folks do have a heart for the work. And so you're listening respectfully to what's the message being communicated. And then you're trying to comfort and respond to the message. So if what you are hearing underneath what's being said is I'm scared, I'm in pain, I'm frustrated, I'm confused, try to reassure the underlying message and then redirect to something that's more pleasant to help a person get unstuck. You know, people with dementia can get stuck. They're kind of like that truck driving down the muddy road and you're in the grooves in the mud and it's just going to keep going down that road unless someone can turn the wheel and get you off it. And sometimes we need to be the person turning the wheel to something more positive. But you don't want to redirect too soon. Sometimes people they do listen with respect, redirect. They miss the comfort step, and I think that can get us in trouble because that's where it can seem, be perceived as disrespectful to the person with dementia. Like you're not even listening to what they say at all. You're just sort of kind of turning them, trying to get them distracted to do something different without really trying to respond first to what's the underlying emotion. So it's a very important step. Okay, the A in the dance is acceptance, realistic expectations. I know I'm talking to the choir in part here, but it is surprising to me. I do consultations in VA settings, and it is surprising to me how many professionals who every day work with people with dementia still expect them to behave sensibly and reasonably. Well, I explained to him that he can't hit his roommate. I told him that yesterday, and I just told him again. You know, it is surprising to me how often people don't understand that dementia is affecting the way a person acts and behaves and reacts, and that people with dementia do not have control over these symptoms. Family caregivers, particularly early on, are particularly troubled by the way these symptoms fluctuate, right? You see it. You have good days, good hours, bad hours. One caregiver does fine, another caregiver is just always having trouble. You know, there's these kind of fluctuating symptoms. And because of the brain disease, the persons with dementia often don't realize that they need help or what kind of help you perceive that they need. And so they're going to resist that help. I like to show this picture to people just to remind them what the extent of the brain disease is. I mean, that's I've got a pointer here somewhere. But you can see, the brain on the right is the brain with Alzheimer's disease. It's full of holes. No wonder the neuronal connections are not working right and people are losing their ability to do things, including not only to remember, but to understand and process verbal information, emotional information. Oops. So realistic expectations in the early stages include you want to make sure people have gotten a medical evaluation to rule out treatable causes of cognitive changes. And that includes when someone has a diagnosis already, but you know, they were pretty good yesterday and now today they're just a mess. Is it possible that this is an Alzheimer's disease? Is it possible that there's an infection on board, that there's some sort of pain that is untreated and undiagnosed, that there's a medication side effect, that the person is overly fatigued, that they're hungry, that they're thirsty? I had someone the other day, they found out in this nursing home at the VA that the patient was itchy. And that was why he had become so difficult to manage, was he had a terrible itchiness that he couldn't say, I itch, so he just acted it out in kind of physically aggressive ways. So we want to always rule out treatable medical causes of sudden behavior changes in even people with more advanced dementia. But early on, we want to try to keep people to be as independent as possible, but expect that it's going to be inconsistent in their ability to do these things. Not assume that their changes are deliberate or that they're just not trying. That's denial. Later on, we want to make sure we're checking on all their safety issues. So what's the hardest thing for a person with dementia to give up? Driving. I love this question because everybody always says that when I do this talk. In my clinical experience, the hardest thing for people with dementia to give up are their guns. People who love guns do not stop loving their guns just because they get Alzheimer's disease. And I have seen terrible things with guns. I have seen people shoot themselves in the foot, fire it through the wall, and almost hit their wife, who's in another room, you know, making something in the kitchen. Point it at their son-in-law who comes to the door because they don't remember who he is. So something to keep in mind, you want to ask about guns if you're working with family people, particularly those of you who are in more rural areas where guns are kind of a part of everyday life. Don't expect the person with dementia to readily accept your help. Do expect, I think, realistic expectations for caregivers means making room for the fact that you're going to be embarrassed, angry, frustrated, really sad sometimes, that that's just part of the package. Nurturing yourself, taking the break when you need it. Caregivers don't take care of themselves, right? Caregivers will take the loved one to the family doctor and will go, you know, to there and back any lengths to try to get help for the person they're caring for, but won't happen to mention that they're having chest pains or that they haven't been taking their insulin properly, or that their blood pressure is out of control every time they go to Rite Aid and they have it checked while they're waiting for a script to be filled. They're not taking care of themselves. But the truth is, their own physical and emotional health is the best inoculation against burnout, the best way that it's going to be possible for them to provide the care that they want to provide. So try to help caregivers find out who in their life wants to help and doesn't know how. People say, well, I don't want to be a burden. But it wouldn't be a burden if you ask someone, well, could you just come over for an hour so I could go run to the grocery store? You know, could you rake my leaves next Saturday? You know, could you, little things. People want to help. And this message that we get, well, just if there's anything I can do, let me know. Well, we never let them know. But if we would let them know, there's lots of people in our lives that would help. And so caregivers need to be encouraged and urged to do that, to try to find 10 minutes every day to do something that they love. I had one caregiver who, she could never leave the house, so she started writing letters. Started out, she had a friend who was in a temporary nursing home stay for rehab, kind of post-hip surgery, and she started writing her letter because she couldn't go visit her. And the friend loved these letters, and she would share them with the other residents around, and pretty soon she said, well, could you write a letter to Sally Mae too? And so then she started writing letters to Sally Mae. like once a day, she'd sit down, spend like 10 minutes drafting a letter, stick a Post-it on it, and stick it in the mail, and people started writing her back. And so she was getting letters back. And she became connected with this whole network. Very little investment, very easy to do, given the limitations of her situation, but it brought joy and relationship and connectedness back into her life. So look for little things that you can do. And respite. You know, caregivers need to get away. None of us can be with, I mean, those of you who are married, or you have kids, think if you had to be with your spouse or your kid 24 hours a day, 365 days a year. You know? I mean, I love my husband, but come on. They would be too much. And yet, many caregivers, that's what they think they have to do, right? That they are the only one that can provide the quality of care. I had one person tell me that when she started going out and letting her stepfather stay at home while she and her husband went out occasionally, that he was so relieved because she had been waiting for, she didn't want to be waiting for him to die before she got out, and guess what? He didn't want to have to die for her to get out either, you know? He wanted a break too, so. Okay, so the whole idea of relaxing too is something that I teach caregivers. Caregivers who say, I don't have any time to relax. So I teach them this mini practice. So here is how it works. You take a long breath. You say the word in your mind, relax. And now you let the breath out slowly. And when you do, deliberately relax your muscles, your face, your jaw, kind of feel heavy. Let's try it again. So take a deep breath in, say the word relax, and as you let it out slowly, deliberately relax. Tell yourself, relax, relax. Now the trick is, you have to do that a lot. Do it many times during the day. So you need to help the caregiver find a time that they can do it. So every time the phone rings, well nowadays maybe the phone doesn't ring so much for that caregiver, but every time he or she walks past a certain point in the house. I had a pharmacist who was still working part-time taking care of his mom, and there was a certain bottle of pills that he had to go back to many times during a shift that he would be there. It was his cue. When he went, before he picked up the bottle, he'd do it. So he'd maybe do that 15 times in a shift. And what happens when you're doing that repeatedly is your body learns to relax on command, right? And that's what caregivers need to be able to do. They need to, when they're in a stressful situation and they're trying to step back, relax. But you can't do that unless you've practiced and you've learned the habit. And this is a very easy way to teach caregivers to relax that does not get into kind of mystic things they're going to think are religious or meditative or, you know, something that might be scary or offensive or just seems like it takes too much time and effort. You want to hook caregivers up with community resources. Obviously, you all probably know your resources in your own area, but make sure that caregivers are reaching out. Okay, C is the ABCs of behavior change. So here's where we're going to teach you how to actually take a particular problem and work with it. So I want you in the back of your minds to think of a behavior or mood challenge that someone you know and are caring for now or have cared for, that you know the situation well and it's something you're kind of wrestling with. Just kind of keep that in the back of your mind as we work through these steps, okay? So we're going to talk about B, the behavior, whatever that thing is that you're thinking of in your mind. What exactly is the person doing? You want to have a good picture of it. We're going to talk about activators, what happens before the behavior, and consequences, what happens after the behavior. We want to focus on behaviors that you can see and count. So what we don't want are things like, he's stubborn. You know, I want to know, what is he doing when he's stubborn that I can see and count? I don't even want something like, he's depressed. What does depressed mean? What is he doing that tells you he's depressed? Oh, he's crying all the time. Okay, he's crying, so that's what we're going to work on. So you want behaviors that you can see and count, that are specific. You want things that matter. So they might be a safety concern, they might be interfering with necessary care, they might just be reducing quality of life for the person with dementia or for you. If the behavior is something that really doesn't matter, he doesn't use his utensils properly anymore when he eats. Well, if that really matters to the caregiver and that's where they want to start, okay, I'll start there. And maybe they'll figure out as time goes along that there's a bigger fish to fry probably than that one. But we start where the caregiver wants to start. The main thing is it has to be something that you can see and count. Okay, so the point of the goals of the ABCs are that if you change the activator, you change what happens before behavior, you can maybe prevent that from happening in the future. If there's an activating context, you know, people say that happens all the time. I do a lot of sleep work. He never sleeps. Every night he's up all night. Well, when you have him keep a sleep log, it turns out that's just not true. He's up maybe 3 nights a week. Those 3 nights are terrible, and so it seems like it's every night, but in fact it's not every night. So, well, that's interesting. Why is it not every night? What's going on the days or the nights that he is sleeping versus the nights that he's not? So sometimes you can identify an activating situation that is a clear trigger and eliminate it, and the behavior will miraculously go away. If you can get rid of activators if you get the right one, it's pretty powerful. Of course, there's often more than one activator. There's a lot of things that are activating a situation, and it's not always the case that you can find that kind of magic to get rid of them, but it can be very powerful. The other thing you can do is you can change consequences. You change your response. So if Mr. Smith gets up in the middle of the night and his wife yells at him to go back to bed because it's 2 in the morning, and he gets mad because his wife is yelling at him, and she starts yelling back. Well, now not only is he up, but they're both wide awake, and they're engaged in kind of this verbal altercation. Whereas if she could find a different way to respond to him when he gets up, maybe redirect him more calmly, more quietly, maybe hear him as soon as he gets up, because there's a baby monitor in the room, so she hears him start getting restless, kind of out of bed, and so can redirect him earlier as opposed to realizing it only after he's in the kitchen, you know, making breakfast, you know, at 2 in the morning. If she can find different responses, then it may get him back to bed more quickly without that agitation and brouhaha. So change the consequences, you can reduce the likelihood of it escalating. You can also sometimes, by changing the consequences, there are some behaviors that are ways to escape. A person with dementia is scared, they're frustrated, they want to get out of that situation, and by doing a certain thing, they get out of that situation. And so there's a little bit of likelihood that they're going to do that again because it is useful. It's self-protective. It's a way of getting them out of an unpleasant situation. And so sometimes changing the consequences can also in the reinforcing power of some of these behaviors. Okay, so we use things that we call actual ABC cards. You can create something in your own charts, in your own system that would work perfectly well. But you basically want a place that you can look at the behavior. You want to ask yourself 4 things. You know, what exactly was the person? 4 W's. Where did it happen? Who was there? When did it happen? You want to spell out the behavior. What's going on exactly? Then the activator, what happened before, and the consequence, what happens after. This observing is how we're going to find the patterns. This observing is how we're going to know that no, it's not he's awake every night. He's awake only on weekends after the kids come over for the big family dinner. Or he's awake only when I let him have that Diet Pepsi right before bed. Or some other caffeinated beverage. You know, people with dementia some of them become very sensitive to caffeine as they get older. Does it only happen around certain people? I remember Wendy Lusbader one time telling this story about how her grandfather wouldn't shower, and it was so frustrating, and so Grandma finally broke down and had a home health aide come and start showering. And her grandfather, it was like a young, beautiful health aide, female, and her grandfather would happily go shower with this aide. And Wendy said her grandmother didn't know whether she should be upset about this, or just happy that it was, you know, so does the problem only happen around certain people? Does it have a cyclic pattern? Is it more likely under certain circumstances? You want to look at all of the possible activating situations. We talked a minute ago about medical considerations. You want to look at what's going on in the physical environment. Are there historical factors? You know, I worked with a woman once who had been in the Nazi camps. And as she got more demented, she kind of went back in time, and so she was reliving being in the camps. So her son would come home from work, and there'd be like all the furniture out in the front yard, and she'd be barricaded into the house. Or the pizza guy would come, and she'd like try to attack him with a butcher knife because she thought it was guards coming to take her away. And it was only really when she got into, we have a wonderful Jewish-based nursing home up in Seattle called Klein-Gallen that is surrounded by beautiful Judaic artwork, and the staff, of course, completely understanding this woman's dilemma and situation, and sort of the rhythms of the religious holidays, and the compassion of the staff, and the right combination of medications as well as behavioral interventions. And this woman ended her life in a very peaceful, good place. But it was because the right context could be created, because she had this history that was now being acted out in her current situation. So we sometimes will hand a chart like this out to caregivers to just remind them all the things we want to think about. If we're working on a particular behavior problem, let's consider, are there medical, environmental, interpersonal, communication, historical factors that are contributing to this behavior happening right now? Like I said, we're trying to keep the whole context in mind, considering the history, considering what the behavior accomplishes. So let's just watch a situation here.
I can't find my watch. Somebody has taken my watch.
Oh, Judy, I'm sure it's in your apartment, and don't worry so much.
It's not in my apartment. Somebody's taken it.
Relax, Judy. I can help you. Look in your apartment.
I don't want your help. You people steal things all the time. I'll bet one of you took my watch.
Judy, no, we don't steal.
Yes, you do.
No, we don't.
I hate it here. You don't care.
Judy, please.
Leave me alone.
Calm down, Judy.
I won't. That watch is gone and I can never replace it.
Okay. So let's talk about ABCs here. So what's the behavior? What behavior would we be concerned with? Call it out. Anger. Accusations. So she's accusing. Okay. She's not easily redirected. So she's, and so the behavior, let's say she's angrily accusing the staff. Okay, so let's go through the 4 W's. So where does this happen? It's at a nurse's station. Okay. And who's there?
One staff.
There's a one staff person and the woman. Okay. And when did it happen? We can't exactly tell in this scenario. So what happened before she got angry, started accusing, started yelling?
She couldn't find her watch.
Okay, so we'd be writing all these things down, right? So one thing, she couldn't find her watch.
So she probably forgot her appointment or was planning on somebody showing up and they were late and it was probably yesterday. My dad does it all the time. Tuesday at noon, Wednesday he wants his watch at 1 o'clock thinking I'm late, even though I was there the day before.
Okay, so there's a good example of where you know a history, you kind of seen a pattern. So it may have nothing to do with the watch. In fact, we don't even know if she still has a watch. She might have had a watch 20 years ago that she was remembering, or indeed, she may have a watch that is misplaced. We don't know that, but we know that she's looking for a watch. What else is going on before she starts yelling and accusing?
The staff member's not listening to her.
Staff members not listening to her. So staff members at the desk, she's like doing her paperwork, right? So when the woman comes out and she's accusing and she's angry and she's yelling, what's the consequence? How does the staff person respond?
She argues with her.
Yeah.
She argues with her.
She
Offended.
She ignores her. She doesn't look up.
Yeah.
She doesn't come around her nursing station. No eye contact, no compassion. What are her nonverbals like? Irritation. Her tone of voice is kind of
Dismissive.
it's dismissive, it's angry. And does that help? Does that whip Judy into shape? You know, we laugh, but isn't that the truth? I mean, we do things sort of on autopilot, and then we're so surprised that they don't make things better. They might have made things better in the past with Judy. Maybe if Judy had been treated that way before, she would have said, oh, you're right. But that doesn't usually work with people with dementia. So what we want to do, we've figured out these ABCs now. You've figured out your ABCs. You want to think, what activators can you change? Or what consequences could you change? So Judy has now gone back to the staff room, and she's having a cup of coffee with her pals. And she's saying, boy, I mean, not Judy, the nurse. And she's saying, I just had this very unpleasant encounter with Judy. I don't want to do that again. So help me figure out, what could I change? So next time Judy comes out looking for her watch and she's upset, this will go better. So what activators could we change?
She could validate.
Find the reason where's her 3 places she leaves her watch. Everybody has 3 or 5 places.
Okay.
People 3.
Okay,
So
so
have that care provider that is taking care of it, goes in her room that she likes, that one, and say, okay, where is it? By the lamp, in the chair, on the counter, by her bed? I mean,
okay, so that's both an activator and a consequence. So one part of the activator side of things is you find out ahead of time where is it that Judy often puts her watch when it turns up
and you put
it's
it
missing.
in a file and call it a day.
Yeah, and so she knows you can look that up. It's also changing a response, because instead of like arguing with Judy about the watch being missing, you're saying go and look for it. Not being dismissive is, I guess, both an activator and a consequence, because she was dismissive when Judy first came out. The response of the caregiver was, I'm not going to do anything different. I'm busy. Leave me alone. And then the situation escalated. So it became an activator for the next part of the sequence that happened.
Right, so if she validated Judy.
Right.
And put her pen down and looked at her and maybe came out and said,
Okay.
oh, that must be distressing. Let me.
Okay.
So the validation part.
So the validation, so that's really changing the consequence. That's changing how she responds to Judy. Is there anything else? Although if she was, I guess if she was not behind the nursing station at all, that would have been changing the activator. But anything else we could change early on?
Greeting.
Greeting.
Yeah. Hello, how are you? What's bringing you up here? Just some kind of verbal or maybe non-verbal communication also.
Okay. So in addition to validating the actual concern, you could just be polite, right? You could, look up at someone and make eye contact and acknowledge, it's a nice day and how you doing, and anything else that we could change in the situation that you could help your friend, the nurse, say, well, try this next time Judy comes out. And what trying means is change the activators or change the consequence. Something that you can change.
I guess if you're really busy, you should schedule, say in 10 minutes, I will come to your room and we will look.
Okay, so you could say, Judy, I hear your concern. In 10 minutes, I have to finish this one piece of paper, and then I'm happy to come look with you. Mm-hmm. Right, yeah.
Something we've used successfully is at that point you can also say, and if we don't find it, we'll fill out a report. And you keep a piece of paper and a clipboard handy and let them fill out a lost report or a stolen report for their watch.
So that's another way of kind of responding, yeah.
Acknowledging her feelings and validating her feelings and speaking to the feelings, not the words that she was saying.
So that's kind of tying in. I can hear you're really upset. I know you really love that watch. So kind of responding in a different way. Yeah.
I wonder if Judy had felt other senses of loss and this was just another thing that I've lost. Does that come here?
So that's kind of looking at those historical activators. It could be that Judy has had many losses, and this is just a metaphor in a sense for her sense of being, you know, abandoned or you know.
I like that, because it's like if you don't know where it came from, it could be your husband's 25th wedding anniversary present, or the kids gave it to her.
So if that was your hypothesis, then how would that change what you would do before or after? We've got a lot of really good ideas for after. Any ideas? Any other ideas for before?
Have a designated place for valuables. You know, have a locking drawer. Have, you know, at where I work, we take inventory of all their belongings first.
Okay.
So before looking for something, if it's someone I know always says it's stolen or lost, then I would say, well, I'm going to go check your inventory first, and I'll bring you a copy, and we'll look over it, and then we'll go from there.
Okay. So that's a thing that in some settings you could do too, is kind of have a designated place. So you're getting the idea. One more, yeah.
The nurse should find a closed door to do work that really can't be interrupted. It looks like she was doing medication sheets, so, you know, if you're behind closed doors, then you're not engaging with others, and you really are focused on what you do as opposed to trying to help do your job, which is what you're
Okay, so that's a whole systemic change. Perhaps it could be that actually it would work better for the residents if when you're on the floor and the residents can see you, you can engage with them as opposed to being involved in other tasks. So those are good ideas. Let's see what was sort of the suggestion that they came up with.
Somebody's taking my watch. I can't find it.
Oh, Judy, are you looking for something? Can I help?
My watch is gone and I can't find it.
Oh, I can see why you're upset. Let's look for it in your apartment.
Not my apartment. You people steal things all the time.
How about we look for it first before we talk about stealing? I'd like to help, okay?
It's no use.
Come on, let's look in the apartment.
It's not there.
Oh, let's look together, okay? Oh, how's that sweater you knitting coming along?
Oh, okay, I guess.
Last time I saw it, it was beautiful. Can you show it to me again?
Oh, I guess so.
Didn't you tell me it is for your niece?
Oh, yeah, it's for my niece Stephanie.
Oh.
And she loves those fall colors.
Oh, so do I. I like a lot. So you...
Okay, so you guys are doing a great job. You think about what did you identify that we saw in this successful vignette? We saw politeness engaging as soon as Judy walks up. There's eye contact, there's a pleasant greeting, there's validating her feelings. I can hear you're upset. She comes around, so she's not standing behind the desk anymore. She comes around before she reaches out and tries to touch Judy. She offers to help her. And then, so she's listening to the concern respectfully, right? She's trying to comfort her that we're going to look together. She doesn't respond defensively when Judy accuses her of stealing. She says, well, let's look for the watch first. We'll talk about stealing later. And then she redirects her to some other topic of conversation. So it's good communication, it's good verbal, nonverbals, it's changing the activators and the consequences. Any questions about the process? So where do you think's the hardest part about it in real life?
Staying calm.
Staying calm.
Because they can get progressively meaner, and they start to hit and yell, and it's like you have no control over it.
And it's really hard when someone's being really mean to you, verbally or physically, to not take that personally. Absolutely.
Having the time, the staff available that you can leave the station, I mean, maybe that's
Get
an
with it
issue.
right there.
Having the time is an issue. That's an important one. The thing with time, though, is it takes time to get into a big argument with people, too. And so in skilled care kind of settings, time is a huge issue that comes up as an apparent obstacle to this kind of behavioral problem solving. But once people get that they can get out of these situations faster or avoid them altogether by implementing these kinds of plans, and you're actually saving time in the long run, but you have to have that experience. You have to kind of have that aha and see it. Anything else about, yeah?
I write behavior support plans for people who are really forgetful, and I put it in the nurse's documentation also. So I make sure they know if they do this, try and respond in a neutral tone, don't cross your arms, get at eye level or below, talk softly or loudly if they don't wear their hearing aid, you know, those types of tips.
So that's good. So these are very specific recommendations that anybody can read them and follow them. If you're going to have a behavioral plan, it's got to be very concrete if somebody other than you is going to follow it up. And the truth is these behavioral plans don't work if I'm doing it from noon to 4, but nobody else is the entire rest of the 24-hour period. There has to be some consistency for these plans to work out. So you have to be able to communicate either across shifts or across caregivers or across family members. We want all of the kids who are coming over to respond to Dad the same way when this situation happens so that there's consistency and it's going to be more likely. It also sometimes takes a little time. So people will try it once and it doesn't seem to work and they go, oh, this won't work. I tried it. I already tried that. Well, they tried it once. You know, you sometimes have to, it takes a while for behaviors that are at strength, that have kind of been learned and have been working for a while to be extinguished. You know, it takes a while for these things to work. Yeah?
I noticed that the staff person, I think she touched Judy. Is that, do you find that that often is a calming gesture?
You know, touch is funny. It sometimes is calming for some people, and for other people it can be very frightening. Or, you know, if you've got someone that's got bad PTSD, touching them can really, you know, set them off, whereas someone else might be very comforted and reassured.
Sometimes there are the people who touch too much.
Right.
You know, so you kind of avoid it because they get a little bit.
Right, so too much touching, touching in certain places. So again, what's wonderful about people with dementia is, you know, what you see is what you get. There's no, I heard someone give a talk once. His wife had early onset dementia. And she was actually in the hotel room up above him while he was giving the talk. And he said that his wife now, it was like he could see into her soul. You know, if they went to a nice restaurant and she was hot, she might stand up and start taking her clothes off because she was hot, you know. All the rest of us walk around with our personas up, right? We're showing one another only what we want the other to see. People with dementia show us their true selves as they are in that moment. And that actually is a great gift to us much of the time. I heard someone else once say that the one thing a person with dementia doesn't lose till the very end of their life is they know what they like and what they don't like. They know who they like and who they don't like. They know what's pleasant to them and what is unpleasant. And to the extent that we can work towards creating a world for them where it's more pleasant, then a lot of these mood and behavior challenges will be reduced, attenuated, and guess what? Our relationship will get better with this person too. You know, if they're happier, we're going to be happier. Oops. So E is enjoy the moments. This kind of all fits in. Laughter and love are good medicine. Pleasant events improve mood. You know, I encourage caregivers to look for the uplifts. Why is it that there's 11 children and you're the one that's taking care of Mom after you took care of Dad, who also had dementia? Why is it you and not the other 10? And there's usually a real good reason for it. Sometimes it's because that person is like just martyring themselves, you know. But often it's because that person really is the one, again, that has the heart for the work. They understand the value of caring for Mom and Dad, and it's part of who they are, who they want to be. So increasing pleasant events can be so powerful. You know, if you're completely stuck with the behavior plan, you can't think of anything else to do, just start increasing the pleasant events. Try to look for ways that in your encounters, every encounter with a person with dementia has the potential to be pleasant. Think about it. You know, whether it's tone of voice, facial expression, creating a physical environment that they enjoy being in, touch, music, pets, children, you know, gardening, whatever it is that for this person in that moment can bring pleasure. I had one person after a conference like this come up to me and she said she was really sad because she'd put her mother in a nursing home. She was a single woman, had to travel a lot for her job, had to leave Mom alone. Mom was getting too demented, couldn't be left alone. And so she put Mom into a facility. And now she was scared that she had done it inappropriately, that Mom really wasn't demented enough that she needed to be moved, because Mom was doing so much better now that she was in the facility. And as we talked, what became clear is in this facility there was a staff person who had taken a particular liking to Mom. And so she would go in every day and she would greet her and she would comb her hair and she would tell her how pretty she looked, and she would spend, you know, an extra few minutes just kind of chatting it up. And what seemed to have happened is Mom became less depressed. And when she became less depressed, she was able to function at a higher level. It wasn't she was less demented. She still needed to have been moved. But her depression wasn't an extra ball and chain. You know, she already has dementia. She already has a broken leg. But now that depression had gone away and the ball and chain that was on the other leg had been cut off, and she could move around better. She could function better in her world because she was happier, because of these pleasant encounters with this person who cared about her. So when you're trying to increase pleasant events, you know, think about what people enjoyed in the past, what do they enjoy now, who's available to help, time. We come up with lots and lots of lists to give people ideas of things to stimulate what might be pleasant for someone with dementia. It doesn't have to be big, you know, we don't have to be taking Mom on that trip to Europe she always wanted to go to. You know, it can be just very simple encounters that take almost no time, are free, can be done over and over again in the course of the day. It just takes a little creativity. My colleagues up in Seattle use something called a pleasant events schedule. It's like 24 items. What I like about the schedule is it rates both frequency and enjoyability, and I think that's important. So if you've got something a person does all the time, so I take Mom shopping with me every day, because that's the only way I can get the shopping done. Well, Mom always hated shopping. So guess what? Is shopping usually fun for her? No. So it's high on frequency, it's low on enjoyability. Alternatively, Mom loves being around kittens. But we don't have a cat anymore because it's kind of a hassle. And so she loves it, but hasn't seen a kitten in months. Well, maybe there's a way that you could increase her kitten exposure. You know, you could go visit shelters. You could do, but you get the point. If it's high in enjoyability and low in frequency, is there a way to increase the frequency of it? If it's high in frequency and it's low in enjoyability, then can you maybe do less of it? Even though, you know, I mean, if I'm planted in front of the TV for hours at a time because it helps my husband get some chores done, but I don't like TV, then I'm likely to get restless and bored and maybe get into some trouble. Whereas, you know, if we could find some other ways for him to get his chores done without planting me in front of the TV, that'd be good. Look for safety bubbles. I like to think of it this way. So these are situations where a person with person's dementia is not relevant. So can you create situations where it doesn't matter if you don't remember things accurately? It doesn't matter if your clothes aren't buttoned quite right, or being with is more important. I'm working with someone now who every week, the wife is the caregiver, husband has dementia. Every week, one of their adult sons comes and takes Dad over to his house. And the adult son has 2 giant dogs. And he has like a really trashy house, you know, the house is a mess, there's all these kids and there's dogs and they're like these really broken down couches. And the dad gets on the couch and the dogs get on top of the dad. And he loves it. So for like 3 hours every weekend, Dad is in dog heaven at his boy's house. It doesn't matter, you know, how tidy and neat he is. The kid's not very neat. You know, the house is a wreck. It's one of those lived-in houses. It's not a house for show. Dad's happy in the environment. The kids and the daughter-in-law love him. And wife gets a 3-hour break. So that is a perfect example of like a safety bubble, a place that's good. Every interaction can be a pleasant event. Pleasant events are everyone's job. When I, you know, consult in facilities, facilities often say, well, that's rec therapy. I'm a nursing aide. You know, pleasant events aren't my job. Well, you know, to the extent that every interaction can be a pleasant event, they are your job. You know, to the extent that we can try to find ways to bring joy, pleasure, peace, and I tell you, I understand whether you're a family caregiver or you're a staff caregiver, when you're having a hard day and you're stressed out, really going out of your way to make this other person's life as wonderful as possible is hard. I get that. Which is why we need respite and why we need other people who are involved. We need people like the son to come and take dad away so that he can be with the dogs, you know, not at mom's house, but at his house. So you can't do it all on your own, but it isn't just someone's job. Pleasant events, like I said, they open up a world of possibilities. If you're stuck, if you can do nothing else that you can think of, you can't think of any activators or consequences to change, just start throwing in pleasant events and see what happens. And you will be astounded at the potency that this has for improving the quality of life for folks. So let me see how I'm doing on time. Oh, I'm almost out of time, but I'm just going to show you one more video. So what I want you to look for is pleasant events.
Hi Alice, how are you today?
Or the lack of.
I don't know.
Gee, you look really sad.
I am sad.
What's wrong?
I feel really lonesome. My daughter never visits me.
I've noticed that. She's not around a lot, is she?
She never comes to see me.
You must miss her a lot. I wish there was something I could do to cheer you up.
Okay, this is a good scenario, I think, because this staff person is not a bad guy, right? He's trying to be very compassionate and understanding and supportive and empathetic. He's trying to listen to the feelings. But did it help? It didn't. So what could we change? What kind of activators and consequences could we change? And how might pleasant events be brought in here? Say that again?
You gotta get her out of the rut.
You got to get her out of that.
Like, he was just reinforcing it.
Yeah.
Talking about it. Like, tell me more about how your daughter's neglecting you. Like,
Yeah,
no.
yeah. My daughter never comes and visits. Oh, you're right. I mean, he says it in such a nice way.
Like, I've noticed that. I was like, no.
Okay, so what else? How else could we change?
Call the daughter. Well, why was she sitting alone in a room with
Why is she sitting alone in the room?
Yeah.
You could call the daughter. It may be indeed that the daughter never visits. Of course, it could also be the daughter left 5 minutes ago and she's already forgotten the daughter was there. We don't know that from this scenario, but I think that's a possibility. See?
Writing a letter.
Writing a letter. What else? How else could we change?
I would actually try to get her mind off of her daughter. I would definitely be like, you're not lonely because I'm right here. Let's go hang out.
Okay, so definitely try to, you know, you're acknowledging she's sad, and let's get her thinking about something else. Let's turn that wheel, get her off that muddy road here.
I think you can kind of mirror feeling positive, like, hey, you know, I think if you come in, instead of with the concerned, woeful connection expression, like you can also kind of shift that into mirroring, like positive, smiling, engaged energy, sort of.
Yeah, so instead of him sort of mirroring back her kind of mournful mood, he could sort of bring her something positive and uplifting that she would then perhaps begin to reflect back. Yeah.
So would it be safe to assume that a new care provider in a situation like that could go to a behavioral support plan and use that as a reference or a resource to find the correct answer of saying, oh my gosh, she's really upset or you know, tired, you know,
Absolutely.
sad, to use that resource
Absolutely.
to help you find an answer.
Absolutely. If you've got a good behavioral care plan, you may even have in your charts, you know, one of these get to know me kinds of things where you list favorite things and least favorite things and don't ever say this to me and I love it when you do that to me, kinds of lists of ideas that will help you. Yeah.
So it's pretty essential for folks with dementia or Alzheimer's to have that behavioral support plan as a guide for care providers.
Absolutely. It's critical in residential care settings. And I would argue it is critical in family care settings because the caregiver needs to remember, you know, when I think about the hardest thing about doing these plans for me, it's in the moment I forget. I have like the best plan, and in the moment I'm just sort of like bowled over by something that just happened, and all my ideas that I had just completely go out of my brain. And that's okay, because even when you mess up, the person with dementia will forget, and then you'll get to try again, you know, the next time the problem happens. But you really, if you have stuff in writing, I think it does make it more easy to do this. Yeah?
I also, I meet with the care staff every other week, and I go over one behavior support plan with them.
That's great. So you go over one behavior support plan every week with a, yeah.
I think it's important to mention, just for semantics, that a behavior support plan or behavioral care plan is usually something that would come after behavior support services is engaged. Not every community is necessarily going to have one of those. I was saying I think it's important to recognize from an Oregon standpoint for semantics that behavior support specialists are usually called in specific situations. So you may not have a behavior support plan, but if you're working in a community, you should absolutely have a getting to know me kind of thing. And if you don't, your community should start having those, because you can't achieve person-centered care if you don't know anything about the person.
Absolutely. I really appreciate you making that distinction, because a nuance like that, you know, I wouldn't be aware of, so I appreciate that. I am aware of my time, and I want to respect everybody else. So let me remind myself how I get out of here. Oops, oh dear. There I am. I'm not going to show, in the interest of time, I'm not going to show you the solution scenario that goes with this one, but I will give you a spoiler alert. What happens was he does walk in with a more cheerful look and a face, and you know, he's very upbeat, and when she says, you know, she's sad, instead of saying, well, I notice your daughter doesn't visit, he does say, well, I'm here with you right now, and it's a beautiful day outside. Have you seen the flowers are blooming? You know, I used to have a garden. Did you? What kind of garden did you have? Let's go look at them together. And so, you know, he does redirect her. So again, many of the ideas you came up with, he follows through on. So just in closing, you know, I'm a big believer in behavioral treatments. I was talking to someone before this meeting started. That's not to say medications aren't needed and useful, you know, sometimes in some situations with some people. But behavioral interventions have the advantage, they're incredibly empowering. When you have a caregiver who has that aha experience, where they get it, where they see that something they do, one of the first caregivers that I met that I got this dancing idea from was someone who managed to get his wife to shower for the first time in months by dancing her into the shower one morning. And I remember I was running a support group at the time, and he was telling this story to the group, and it was like this huge aha for him. He realized that she hadn't just been not showering to irritate him, and that it had love behind it. It was an intervention that had creativity, it had humor. He kind of like shimmied her out of her jammies as he danced her in the shower in the morning. You know, it had all of the pieces, and it gave him a sense, I can make a difference for the better in this situation. It's incredibly empowering. Oops. See, I'm completely flummoxed here. This is what happens to me. I get like talking, and then I like lose control of time. So ABCs, they're simple, but they are tricky, right? I've had people say, this is too easy, this will never work because it's too simple, it's just ABC. Well, it's tricky for all the reasons we've been talking about this afternoon, right? There's a lot of things to consider. It is harder, it's easier to say than it is to do. If you try to fix everything at once, it could be overwhelming. You have to get people to just, it doesn't matter where you start. It's like a spider web. All these problems are interconnected to one another. And it doesn't matter which problem you start with first. If you start anywhere, you can make a change that may have huge chain reactions and also greatly improve your relationship. They're not crisis management. Caregiver told me once she woke up in the middle of the night and her husband had a sharpened, pointed pencil poised to poke out her eyeball. That was not time to try an ABC behavior plan, right? I mean, she called 911 and he had to go to geropsych. I mean, it was a dangerous situation. So these are not emergency solutions. And, you know, you have to have everybody involved in care. It has to have consistency. Nothing works all of the time. You know, there is no magic bullet here. You're not going to get rid of all your problems. If you can reduce the frequency, severity, and duration of these problems, and or reduce how disturbing they are to the caregiver when they occur, because you have greater understanding and empathy, then all of those are good outcomes, even if the problems don't completely go away. And even if the problem does completely go away, next week there's going to be a new problem. So, you know, as long as we're providing care to people with cognitive impairment, there's always going to be more problems to work on. But, you know, they do work. So, anyway, I'm out of time here, I think. So I'd be happy to take any questions if anyone has them. Or, yeah.
Can we just use your ABCs? Or do we need to pay you? Or
No. No, I'll tell you what. My colleague Linda Terry was one of the first ones to apply ABCs to dementia care, but she was not the first one even to do that. ABCs have been around since B.F. Skinner. You know, they're basic behavioral principles. They're not copyrighted at all. I would love it if you used them. And if you ever wanted to, like, email me and say, I'm trying to do an ABC, help me think this through, I'd be happy to do that for you, because I really think this is elegant work when it's done. I can't tell you how many times I've seen this make a difference in different people's lives. And you need encouragement and support. I encourage you to brainstorm with your colleagues and your friends and your family members. You know, don't try to just develop plans on your own. Get as many ideas as possible from as many people as possible. Yeah.
And if you're going to be writing something up, it's a good idea to keep in mind that what works at 10 a.m. in the morning may very well be a complete loss to you at 7 p.m. When you've got sundowning happening, you've got a whole different human being between morning and night.
Yeah, so the point, what works in the morning may not work in the afternoon, but see, that's where the ABCs are so, it's so perfect, because it's a different context, right? It's a different time of day. There's different environmental, different biological, different interpersonal, different factors going on. So that's the power of looking at the context. Behaviors do not come out of the blue. There's a reason why they happened to me today and they didn't happen to you yesterday. There's something different about today and yesterday, and it may be me and you that's different, or it may be something else that's different. But the more you can figure out about what's going on when a behavior happens and what's going on when it's not happening, then you can come up with these ideas. And the more ideas you have, the better, because you can just start trying them. Try them one at a time. Don't try them all at once, because it'll be too much if you try them all at once. But any other questions? Yeah.
And also, because I've been doing this for a long time, I always ask the family if the client does something, I ask, what did you do when they did this? Or what did something mean? You know, like, why is the brown shoes so important? Lo and behold, that's what they wore to church, so you get their Bible out and listen. Or if it's the watch, you know, why do they act this way? Like, my dad was a cop, so he'd go into his cop stories, and then he'd get angry, but I'd divert it before he'd get mad. So you have to understand why they're acting that way. And it helps if you ask the family members, because it could be an old story. Because my dad goes back
to get some of that
42
history.
years ago.
Get some of that
story.
history.
Well, being with him for 20 years, I remember that, so I can help. But not everybody has that experience.
I mean, sometimes, why is a tricky word? Because lots of times you'll say, well, why does this happen? And say, I don't know. If I knew that, I wouldn't be talking to you, you know? I mean, that's why I like activators and consequences, because if you say, you know, why did it happen? Well, I don't know. But if you say, what was going on before it happened? There's always something going on before it happened, just because of the way time works. So you can always come up with things that were happening before. And then if you say, well, what was the consequence of that? Well, that question isn't very good either, because the caregiver often say, well, I got mad. Well, that's not the consequence that we want. It does matter that you felt mad, but what matters more is, what did you do when that happened? And did that make the situation better or worse? So you have to, and again, if you ask what happened after, there's always something that happened after. So when you're looking at what happened before and what happened after, that gives you very specific things you can think about changing without having to get too kind of intellectualized about it where we can get stuck. So.
Well, thank you.
Okay, you're welcome.